My back?
We want to see the entire screen.
Okay.
If you don't mind.
Oh, no, that's fine. We can put it over by the window.
Ahora sí.
How's our time? What time are we supposed to start? Do we know?
They say 6, but I've heard people saying 6:30, so I'm not sure if someone is coming.
Okay. I'll wait until they tell me to start. What's that?
When you want.
I can start?
Yes.
Okay, so are we going to just do this where I do the presentation in English?
Yes, we did.
Because my Spanish, as you know, is not very good.
No problem.
Somebody can translate later?
No, they understand.
I mean, since you're using technical terms, I think everybody will understand what you're saying.
Okay. Okay. We'll try to just move on then.
Right now you are online.
We're online?
By Las Américas.
Okay, good. Great. All right. So just wanted to welcome everybody to Las Clínicas, Américas. It's a real pleasure to be here this evening from Scottsdale, Arizona, which is where I live and practice orthopedics. It's our second visit to Medellin and first mission that we're running here, and it's a real pleasure and an honor to be here and helping the people of Colombia. So what I thought we would talk about this evening, Dr. Patterson is supposed to give the second talk, but I think he chose to be in the operating room doing surgery instead. So I may be giving both talks, but we'll see how the time goes. How much time do we have allotted? Do we know? Okay. Okay. So if as we're going through the talk, if you guys have questions about any of the topics or anything like that, just stop, raise your hand, let me know. Again, this is education for you that we can hopefully share. So talking about knee replacement in the 21st century, really to kind of approach it from 3 ways. One is changes that are occurring in the design of our total knee components. And then the other is to talk about the techniques in terms of how we do these surgeries. Obviously, there's a lot of other moving parts and things that are changing in knee replacement, hip replacement in our world, but just to focus on a couple of these things. So we'll talk about what's called the physiologic matching, which is the design of a prosthesis, the robotic-assisted total knee replacement, which is something that we've been doing since last year with the Navio system, as you see demonstrated here on the slide. So when we look at the goals as surgeons of what we are trying to accomplish for our patients, we have different goals from our patients. So I think it's important to differentiate that, because what's important to us may not be all that important to our patients. So I put down that for me, I want to have as natural knee function and motion as possible for that knee replacement, with the most accurate procedure that I can perform that has let's see here, we lost our feed, HDMI. Is it one of these right here?
Oh, duplicate. No, pero ya parece que lo está leyendo. Espérate, démosle un segundo. Ah. No, signal.
Okay. Could be the.
No.
Okay.
Ahí está conectado.
Just maybe unplug it, plug it back in, or plug into the side. No, it's okay. Technical difficulties.
Pues que estaba funcionando perfecto.
Perfecto.
¿Qué vas a tirar este otro? Changes. Aquí.
That one, yeah.
Apaguemos el computador y prendamos. ¿Ah? Sí.
Apagó el sifón. Iniciamos el computador.
El computador. You can.
I can put it on a the zip drive here.
Try to restart the computer, please.
Okay, let me just save it.
Or we have for this USB put in the other computer.
Okay, let's just try this.
Pongamos aquel por el otro cable, por el VGA, sí.
Interesting challenge.
Dale señal a este ya.
Ok, está bien.
Y esta aquí. Bajemos desde acá. Listo. Entremos ahí ya.
Yo sabía que estaba. Vamos a manejar. Sí, porque manejamos rápido.
There it is. Ok, está bien.
Ok.
There.
Perfecto. No vamos mucho.
Ok, está bien. It's okay. There it is. Okay. Okay. Sometimes doing knee replacement surgery is easier than doing audiovisual work, for me at least. All right, so we're going to move through here. So kind of hit the agenda again, what we're going to talk about this evening, and go here. So when I look at what I'm trying to achieve for my patients in knee replacement surgery, they're kind of threefold: natural knee motion and function, the most accurate surgery I can perform as a surgeon, and then improving the clinical outcomes through precision. Okay, and those are really my goals. But again, my goals may not match up with patient goals. So if I were to look at these x-rays of knee replacements that we've done recently, I would be pretty happy with the outcome. But that does not guarantee that the patient who owns these knees, these new knee replacements, is going to be a satisfied patient. Okay, so the patient goals are pain relief. Let's see if there's a pointer on here. Sort of. There it is. I got it, Claire. Okay. Pain relief, what they would consider to be a normal knee, their ability to return to life or to work, the least invasive surgery, and the quickest recovery. Okay. So those are the goals of the patients, which admittedly I'm trying to provide for them. But again, sometimes our goals aren't always meeting in the middle, so to speak. So a happy patient like this or a happy patient like this who's attached to this x-ray, all of us are happy. Okay, the spouse is happy, I'm happy, you know, it's a home run, as we say in the United States. Okay, but we know that there is a dissatisfaction rate with knee replacement that can be as high as 20% of the patients. So the patient-reported outcome would say that 1 in 5 patients is not going to be very happy with the outcome of the surgery that I did for them. So whether it's, you know, just playing golf or walking. And these are studies that go back over the last 10 years. And we haven't really been able to change that number. The most quoted number is probably 15% of patients, maybe not as much as 20%, but still that's a fairly high number of patients who are not happy with the outcomes of their knee replacement. This is a functional study reporting all these different activities, and you can see satisfaction rates that sometimes are good, sometimes are not very good. Okay, and people want to live their life after we do their surgery. So what impacts the results that influence the outcomes of activities like this? All these different six different variables all influence the outcomes. But what we're going to focus on today is really the component design and how accurate we can be as far as the implantation of our knee replacements. Okay, so there it is, and there it is. Those are the two our focus this evening. So we have to ask: is the present component design, how the prosthesis is designed for knee replacement, does that allow the patient to walk normally, like I do when I walk down the hall? And the answer for a conventional knee replacement really is probably a no. All right? And we say that based on research that has assessed how the patients walk. Okay? And specifically, we see all these changes that occur. The velocity or the speed at which they walk decreases. The stride length, how long their steps are, decreases. Knee flexion, mid-stance is a orthopedic descriptive term. And then the swing through phases with flexion. In other words, people tend to walk with a little bit of a stiff knee after their conventional, traditional knee replacement that we've been doing for the last 20 or 30 years. So we have to say, okay, how does that translate based on studies? And they've done all sorts of studies on the quadricep muscles, and you'll see that in a conventional knee, this is what we want it to do. This is what happens when a knee is bending. So the knee is not just a hinge, okay? The knee is a complex anatomical structure where, if I go back here, you know, there's amplitude in the muscles. All these muscles are working, but in a knee that's been replaced, sometimes it will require 3 times the energy to have the quadriceps muscles working normally or close to normal in a patient that's had a knee replacement. And if we look at some of our older patients, that's a lot of increased energy and strength that they don't have. So can we change that? So again, this is how my knee works when I walk down the hall this evening. That's how I want my patient's knee replacement to work. But this is what a conventional or knee replacement does when it's bending. It's moving all over the place. And it's certainly not moving like the normal human knee. Let's see if I can get it to go here. So again, if you watch what that line does, it pivots around a medial point and then it slides backwards. So this is a complex motion that the knee is doing. So the challenge in orthopedics from a biomechanical standpoint is, can we restore or recreate this type of behavior with the knee replacement when we know that what we've been using for the past 20 or 30 years is really doing this, which to me is not very good. So the knee does all sorts of different things. So again, it's not a simple hinge. We don't have to go into all the details, but basically at different points, whether the knee is straight, slightly bent, or bent to 90 degrees or more, the knee is doing different things as far as rotation, translation, as well as the flexion. Okay? So the engineers have seen this as a challenge for many, many years, but they really have not been able to address the challenge with a good comprehensive knee replacement design until fairly recently. So when we look at, again, we won't belabor these points too much, but the design of the knee replacement, how this design is, the curvature of the prosthesis, the shape of the prosthesis, the shape of the polyethylene, which is the material that's used to replace the actual cartilage itself, is very important in terms of the overall function. So it used to be that polyethylene was just a piece of symmetric plastic that was the same on the inner part of the knee and the outer part of the knee. But again, the engineers who were smart enough to work on this challenge realized that they could redesign some of these implant factors and change the way the knee works. So again, conventional knee has what we refer to as paradoxical motion with lateral pivoting instead of medial pivoting. Again, we can go into the technical part of that. It's probably a little bit out there as far as the sophistication. But the question is, can what's referred to as physiologic matching of technology, changing the implant design based on what we know the human knee does, will that impact how the patients do? So Smith and Nephew came up with what's called the Journey knee replacement. BCS stands for bicruciate substituting. And their goal was to recreate normal kinematics within the patient's knee, ultimately to improve the patient's function. All right, so these aren't technical things that we as surgeons are doing differently in the operating room. It's things that the engineers have worked on in the laboratory based on studies of CAT scans of the knee, based on MRI studies, and based on dynamic assessment of what the knee does under live fluoroscopy. So there are several labs in the United States that have done extensive studies of this, and it's remarkable the data that they have generated over the last, like I said, 20 or 30 years, and that data is now coming into the operating room for us as surgeons to give to our patients. And that's quite remarkable. So let me just go back here. It tends to want to progress on its own. So with this new design knee, it's the Journey 2 BCS knee, we want to try to match the normal knee so that when the patient is walking, and the EMG studies, which are the neurologic studies of the quadriceps, are basically the same in the knee that's been replaced as opposed to the knee that's healthy that has not had surgery. Does that make sense to everybody? Okay, so again, the challenge for engineers is, can we replicate a complex joint, the knee joint, because what we've done in the past has not worked. So we see flexion, the ability for the patient to bend the knee that's over 130 degrees quite consistently now. We see kinematics, which means live x-ray, let me go back here, showing that, again, the knee with this Journey 2 knee design is actually functioning the way the normal human knee does before the arthritis set in, before the patient had to have surgery. Okay, so ideally, you know, we could have a video of a patient walking when they're 20 years old, okay, and they're walking normal. And we have an MRI or a CAT scan of that knee when it's normal, when there's no arthritis, when there's no deformity. But realistically, we can't do that. So what do? We build a design that basically takes healthy knees, takes millions, thousands of x-rays, MRIs, and then uses that to basically bring together a design that will replicate the normal function of the knee. So in knee replacement, we're cutting away small pieces of bone and replacing that with metal and plastic. The challenge, however, is that if we create a rectangular space when normally the top of the tibia down here has a 3-degree pitch to it, and we take away a rectangle of bone, we can't create that normal 3-degree pitch. All right, so the kinematic approach is what we're talking about here. With this new knee system, we're creating this rectangular space, but what we put back in is not a rectangle like it has been traditionally. It's an eccentric piece of plastic or polyethylene, as you see, that's thinner on the medial side of the knee, the inner part, versus the lateral part here. And it is that way both when the knee is in full extension and when it's in 90 degrees of flexion. Okay, and what that does is it forces the engineers to change the shape of the prosthesis if you're looking at it from above or on face, so that again the prosthesis is a bit thicker here and thinner here, so that it still fills up this rectangular space with the same width on the medial side and the lateral side. Okay, so it's a fairly radical change in terms of the thinking, because up until this system came out, there's really no polyethylene that's designed where it's thicker on one side than it is on the other. Okay, so they've changed a lot of different things in terms of the shape of the femur, so that it's kinder as far as how the patella, the kneecap, tracks on the femoral component. They've made small adjustments to the shape of the polyethylene that allows the appropriate rotation to occur through the knee. And again, they've made the eccentric so that the polyethylene is different on the lateral side, the outside, versus the medial side. Okay, so if you have a chance and you look online nowadays, you can find everything under Google, of course, so it's easy to find and see what this piece of plastic looks like and see how it's different from the conventional polyethylene and knee replacements. So when we look at the effect of this new implant design on the ligaments, which are the collateral ligaments, so those are the ligaments on the inside part and the outside part of the knee that stabilize the knee side to side, we see that in the conventional knee, this is yellow here, it's fairly consistent all the way across. But the normal knee, the native knee, doesn't do that. It actually has a slope downward. With this new Journey 2 design, the new knee design mimics the normal knee, and that's the medial collateral ligament. You come over to the lateral side, the LCL, the lateral collateral ligament. Again, this is the conventional knee, but this is a normal knee, and now you see that the new knee design actually mimics the LCL function. So this is not just about designing a knee that looks like the normal human knee, but it's actually designing a knee that looks and functions the same way as a normal human knee. Okay? And this is what I was showing earlier. Quadricep effort. And this study, that's now 6 years old, showed that with the Journey 2 knee, it matches the normal human knee, the non-operated leg of the patient, almost perfectly. So for an engineer, thank God we have smart engineers in this world, to come up with this is really truly innovative in that sense in the knee replacement world that I live in. So again, if we look at the Journey 2 knee, and you see how that one's moving, compared to how you saw the normal knee move earlier. Let me see if I can get this to run here. Okay, so we'll run that one more time. So that's the new knee design, and if you recall, that's exactly how the normal human, I shouldn't say exactly, nothing's exact, nothing's perfect, but it is very close to how the normal human knee functions when it goes through a flexion extension arc, compared to the conventional knee where the knee is sliding back and forth with what we call paradoxical motion. So Journey 2 knee is now available in our primary cases. It's also available in revision surgery, redo operations, and so we can apply this new technology in pretty much any knee replacement that I'm challenged with in the operating room. So for me, this is innovation that is going to impact the result of total knee replacement through changes in component design. Other factors are still important, and we're going to talk about this next, but the change in this design has really made a difference for my patients. And the patients know the difference within a week. So when they come back to see us 7 to 10 days after their surgery, they say, yeah, Dr. Copper, this knee feels good. And my physiotherapists tell me the same thing. I didn't tell my therapist that I changed prosthetic design a couple years ago. I just wanted to see if they could tell a difference. And within 2 or 3 months, several therapists came to me and said, what are you doing differently? And I said, I'm not doing anything differently. They said, well, something's different. I said, well, we changed the design of the prosthesis that we're using. So that's a pretty good objective feedback that I've gotten, that this is a real difference for our patients. Because there's a lot of empty promises. You know, we have a saying at my house that we don't want to be over-promised and under-delivered. Okay, which leads only to disappointment, of course. So if we can do better for our patients, everybody's going to be happy. Me as the surgeon and my patient and their family. Okay. So anybody have any questions about that at this point before we move on to some robotic information? Okay, that means everybody understood everything perfectly, and my Spanish is bueno. Okay. Excellent. So we talked about component design. Now we're going to talk about, is there technology available that will make me a better surgeon to put this new knee design in the patient's knee? Okay? So surgical accuracy historically relies on this computer that we all have in our brain. Okay, the experience that we've gained, what we've been taught by our mentors, and what we recall and what we apply in the operating room. But as in many, many facets of our lives now, robotic-assisted technology is coming into the orthopedic operating room, right? So car manufacturers, there are very, very few people working in the factories anymore. It's all robots doing all the work, right? We're not quite there yet in orthopedics, but we're starting to head in that direction. So let's talk a little bit about what a robot looks like in orthopedics. I don't know if you guys remember TV shows from the 1970s that had robots that looked like this, or robots that looked like this from the 1970s as well, Star Wars 1976. My son is a very large Star Wars fan, and he said, Dad, you got to put a Star Wars slide in your talk. The people in Columbia will love it. I said, okay. But we're also not at the point where I have a robot and this is me, Luke Skywalker, in the operating room. We're not there yet. But I say yet because, you know, technology is just going to advance as time goes on. You know, 10 years ago, we all had a little flip phone in our pockets, and to send a text message, we'd have to hit the number pad to send, you know, 6 words would take like 10 minutes. Now we have a computer and our cell phones, the smartphones, and we can Google search everything, and WhatsApp. I can message people down here in Colombia, and it doesn't even cost me anything. It's remarkable. But we're not quite at this stage yet in orthopedics. So there are 3 types of robots in the medical world, okay? There are active robots, passive robots, and semi-active robots, okay? So an active robot means that the robot is programmed, we hit start, and then the robot does the procedure itself, okay? Surgeon's not involved. Passive means that it helps us do the procedure, but we're still doing the operation. So it might hold surgical retractors or protect tissues around the surgical field, but we as the surgeons are still doing the work. Semi-active is the world that I live in now, where basically we use or augment and help a surgeon's gesture with a virtual template. And I'll show you what that means, because it sounds kind of abstract. Even to me in English it sounds abstract. I'm sure in Spanish it's very abstract. But basically it's a shared action between the robot and the surgeon. Okay, that's what we're doing now. So why should we do this? Well, it's all about the, again, engineering terms known as accuracy and precision. So I'm not an engineer, but I have good friends who are. And so I asked him, what does accuracy mean? Well, accuracy means, can we hit the bullseye for the patient that I'm operating right now? So proximity of measurement to the true value for the problem that's right in front of us. So when I look at this x-ray, this case went very well with robotic technology, okay? But that's one case in time, right? Precision refers to repeatability or reproducibility of that same measurement, all right? So that means, can we hit the bullseye 3 times in a row? Can we do that 3 times in a row? Okay? So I stand up in meetings, show these x-rays, and I'm open to criticism. We can always do better, but I'm pretty happy with how these patients' x-rays look. That is what the engineers refer to as precision, getting it the same way every time. Okay, reproducibility. So, but to bring a robot into our operating rooms, number one, for me, it's about my patient safety. I'm not going to bring some high fancy technology into the operating room that I don't trust as far as the safety of my patient. So some of that has to do with the surgeon staying in control, which is hard for me because sometimes I take that control outside the operating room, and my wife has to remind me, honey, you're not operating when you're at home, right? You don't always have to be in control. So we've been married for a long time, and she understands me better than anybody. But anyway, so safety number one, efficacy and efficiency. Efficacy means how effective is it? Efficiency means, can we still do this surgery at a reasonable pace? It doesn't add 2 or 3 hours to the surgery, which is a lot on the patient when they're under anesthesia for hours and hours and hours. Okay? So for robotics and knee replacement, partial knee replacement, total knee replacement, we're trying to accomplish these goals: simplifying, enhancing the accuracy, balancing the soft tissue envelope, but ultimately the durability is what the patients want, right? I'm routinely asked, Dr. Keper, how long is my knee replacement going to last? I don't know. Well, how long do you think? 15 years? That's pretty good. How about 20 years now? Maybe 25 or 30 years, right? So I'm operating on younger patients, just like we did today here in the hospital, some young patients who need surgery. They might have a life expectancy of 20 or 30 or even 40 years. The longer this is going to last, the happier they are, right? So the durability is very important as far as the patient's concerned and mine. So as a surgeon, I want to do one operation for that patient, have it go very, very well, and that way we never have to operate on that knee again. That to me is the success story, okay? So when we look at, and we talked about this is what a computer used to look like in 1970. It would fill up an entire room like this, right? And now it's in the palm of our hand, right? So robotics started in the early 1990s, and they look like this, and they have progressed, and now we're using handheld robotics in the operating room. So people, again, have that notion, have a thought that a robot has to be a big thing, or it has to be big and bulky like the Star Wars characters. It doesn't have to be. It can be in the palm of our hand nowadays. So the Navio system is in evolution, just like everything else in our world. Our cell phones, our TVs, our Wi-Fi, whatever that might look like. Everything is in evolution, and what we have today, we'll 5 years from now, we'll say, wow, that was okay, but look at what we got now. Okay, so it's really interesting to see where this curve is going to go in the future. So again, just the highlights of the different steps that where we are. So this was designed by some of the robotic engineers in Pittsburgh that were part of Carnegie Mellon, and I've gotten to know several of them. Very, very smart individuals. And so they basically, designed this semi-active robot that does not require us to do anything in the way of an MRI or a CAT scan of the patient's knee to do the surgery, which was the first generation of robotic knee replacement. It's a small burr tool that we use with a computer program and a digital screen. Literally, this is the entire setup for the robot. Okay, and this is the next generation coming out this year is going to be even smaller. Okay, so it looks like this. There's a 3D camera. There's a burr that I hold on to, and the touch screen and the computer, and then we put pins in the bone with a sensor so that there's a direct communication between the patient and the computer during the surgery. Okay, so what I can do with that is then basically have the camera detect these little sensors that are attached to the patient's knee and my burr, and there's real-time imaging, so I can watch myself do the surgery in real time on the computer. And if I don't like what I'm doing, I can stop and I can change it, and we can reset the program. So I'm in complete control, which as a surgeon I like. Again, my wife doesn't, but I like it. So handheld tool, communicating through the camera, information fed to the computer, and then foot pedals for our controls. So again, that's what that looks like. Let's see if we can just move through that slide. The camera, won't bore you guys with details. So basically, like I mentioned, we attach these trackers to the femur and the tibia. Okay, we then collect the data intraoperatively, not having to expose the patient to a CT scan or the cost of an MRI, which is not inexpensive, whether we are here in Colombia or in the United States. We then collect different data points that allows us to build a three-dimensional model of that patient's knee through a surface mapping technology in real time. Okay, so we collect a rotation of the hip, we collect the center point of the knee, the center point of the ankle, and the computer then tells me the angle that the knee is at. So one of the knee replacements we did this morning, she had a valgus knee, a knock knee that was almost 20 degrees off the normal. It should be like this, and her knee was like this. The computer would have collected that data as I'm working on that patient. Knee rotation, we collect that. We then literally take a probe that, again, communicates to the computer, and I just run the probe over the end of the thigh bone, and while I'm doing that, it's collecting all these data points and creating this three-dimensional model of the end of the femur, the end of the thigh bone, on the computer in real time. So there's no delay. It's amazing. I mean, every time I get to do this, it's remarkable. We do the same thing on the tibia. We create a model of the proximal tibia in the operating room. And this all takes literally less than 10 minutes. Okay? So then this is the video. Make sure this is going to run here. Hopefully. Again, I am a knee replacement specialist, not an AV specialist. There we go. So the probe is right here in our hand. Okay, and as I'm moving it here, you can see it's collecting the data here. So you can see from the side view and the top view. And as we're moving over the top of this cadaver, the computer is taking all this information in and building this three-dimensional model here on the computer. Okay, so that when this model is built, we know what size prosthesis exactly the patient's going to need. So I never have a patient come to the clinic again or come in and say, well, how do I know you used the right size? Well, we measured your own bone because we created this model of your own bone in real time. So then in knee replacement, there are two techniques that we use. And again, this is a bit technical, but it's measured resection and gap balancing. So basically, this is the model of the knee that I create from the side view, and we can say, okay, yes, we're going to use a size 7 prosthesis based on the size of this knee. We're going to place the prosthesis so it's not rotated inward or outward, and we can make all these fine-tune adjustments based on all these different buttons, and it's just on my touchscreen computer, okay? So it's no different than my laptop. And so my wife now says that I go to work and play video games, which is kind of true, but yeah, the video game is real life. So these are what the company recommends as far as how much bone we are removing, and I can program that into the computer while I'm doing this surgery. So then we can place the prosthesis on the model and see what it looks like. And if I don't like the size, I can go up or down. If I don't like the position, I can move it up. I can move it forward, backwards, to the side. I can rotate it. I have complete control within millimeters and degrees of this knee replacement surgery. Same thing goes for the tibial component. We build the model, we place the prosthesis, we measure the slope, which is the pitch of the tibia on the upper end, and we make sure this prosthesis is going to fit well. And again, based on the measured resection depths. Then what we are able to do is measure the tension in the ligaments. I mentioned earlier the medial and lateral collateral ligaments, that those need to be stable for the patient to say the knee feels good. Well, we can then measure how tight the knee is when the knee is out straight or when it's bent to 90 degrees based on this graph right here, and I can make adjustments in the prosthesis before I ever do the operation. Right? Used to be, we do the operation, then I'd feel in my hands how loose or how tight it was, and I would make releases or loosen a ligament, in other words, a little bit to make it feel more stable. Now we do this all on the computer before I ever put a saw to the bone or a burr on the bone. Okay. Same thing here, we can adjust, we have the balance. So then once we have done all the work, we put what's called the trial prosthesis in, and then we can take the knee through a range of motion. We can stress or put tension on the ligaments and see how stable this knee is all the way through the arc of motion, 0 to 140 degrees or more. Okay, so this is technology that we didn't have available until last year, right? And this is what we get to play with now. Like I said, 2 years, 5 years from now, again, this will look outdated, and there will be something even better. All right, but this is today. So this is literally what it looks like. There's a burr that I'm using right here, and you can see as my hand is moving, the bullseye is moving. I'm trying to create this little tunnel in the bone right here, and we basically burr that out. I'm taking away the bone, and when all the blue and green goes away, I stop the burr. There's a fail-safe that if I get outside this circle that I'm trying to burr here, the burr automatically stops. Okay, so that's the safety component. So it's making sure that I'm not doing harm to my patient. All right, so again, drilling these holes allows me to put the instruments on there so I make the cuts as precise as possible. Same way every case after case after case. Same thing on the tibia. We burr out these burr holes that put the cutting blocks in exactly the position I want, so I can make the cut so that it's the right orientation, not tipped too much this way or this way, not shifted too much to the front or to the back, and all this is now within our control. Okay, so again, it's about control. So this is the option of using a burr to do the whole preparation, and you can see that we've advanced this. It's a bit quicker than in real life, but with the burr, we're basically removing all the bone that the computer tells us to, so that we are shaping the entire end of the femur so the prosthesis will sit on there snugly and fit like a glove. Okay. So again, this is what the knee would look like. This measures the tension of the ligaments, and you see how smooth and flat that is. That means that knee is stable from full extension all the way to deep flexion of this knee. Okay. So what is this Navio robotics? It's a semi-active robot, meaning I'm still working the robot. It's a handheld robot, but I'm still in control. We use it with the Smith & Nephew implants. Smith & Nephew is the company that generously has donated all the implants for Operation Walk International's mission here this week. So needless to say, we're indebted to Smith & Nephew. But to their credit, they also have the smartest engineers in the business. It's reproducible, it's a small size, and it's user-friendly. Okay, it's not a gigantic robot as big as my operating room. So learning curve, we've done, this is a slide that's about 2 months old, we've done about 150 cases. My first few cases took me a while to learn how to use this system, but as with anything in life, the more you practice, the better you get, right? If you're a soccer player, a football player, like Ronaldo yesterday taking a penalty kick, right? He nailed that top right corner because he's taken that shot thousands of times. He's practiced penalty kicks thousands of times. He knows exactly if he's going to go upper right, upper left, lower right, lower, or lower left, lower right. He knows. And how can he hit that spot? Because he's done it over and over and over again. So as we do more surgeries, literally we're now able to do this surgery in under 1 hour with robotic technology. So that's pretty remarkable. Credit, again, to the engineers. We did a live webcast at the end of August last year. So if you're having a problem with insomnia, you can't sleep, you can watch our video. Okay? So again, right now it started with partial knee replacements. Now we're using total knee replacements. We did I did a few surgeries on Monday before we came down here to Columbia. 2 of them were revisions, now using the robotic technology, which is really kind of just pushing the envelope how much we can use this new technology to the advantage of our patients. It's going to go into hip replacement soon and probably go into the world of sports medicine as well. So we as joint replacement surgeons are not the only ones who are using robotics or will be using robotics in the future, needless to say. So so this is my home state, Arizona, in the United States. A little different scenery than Colombia. Lots of cacti and desert, but it's a beautiful place if you ever come out for a visit. All right, with that, I don't know how I did on our time, but we'll stop there and open the floor for any questions or concerns that you guys have about robotics. Everybody ready to have a robotic knee replacement tomorrow? Okay, good.
First, thank you very much for staying here.
Our pleasure.
I am talking about my personal case. I was in an accident 4 years ago, and right now I have arthrosis post-traumatic. And my doctor said that I am a young woman and he can do a replacement right now. And I am concerned because how many years more I have to wait for surgery because I have pain on days, I have some disabilities for doing some things in my life. And what do you think about that?
Right. So it's an excellent question, and it's a question that we hear a lot. So is there an appropriate age when a patient can have a knee replacement or even a hip replacement? And it used to be 20 years ago that if you weren't 65 years or older, the surgeons, we would say, you're too young to have that surgery done. Nowadays, I don't use age as a criteria. In other words, I don't say, oh, you're 42 years old, you're too young. We operate on young patients with the realization that that may not be the last surgery that you're going to have on that knee or hip, okay? In other words, our own body parts wear out as we get older. Artificial body parts will wear out too. But because we are much more comfortable doing what we call revision surgery, which is redo surgery on a patient who had a knee replacement 20 years ago or a hip replacement 18 years ago, that's what gives us as surgeons the confidence to tell a younger patient, you know what, if your pain is severe and your quality of life is compromised and you've tried everything else, physiotherapy, medications, injections, braces, then we will consider surgery. So in my practice, there's no absolute age how old you have to be to have a knee replacement, but certainly for the younger patients, the best advice is put it off as long as you can. But if you get to the point where things are not good anymore, then have the surgery done. Okay?
He wants to ask a question, so he's going to tell me a question.
Perfect.
Una pregunta respecto al diseño de la prótesis Journey Plus. Okay. Es una pregunta en relación al diseño de la prótesis Journey 2 de Smith & Nephew. Eso que pasa, que usted dice está pasando a los 2-3 meses con los pacientes, de que algo está pasando que va mejor que con los otros diseños, tiene relación básicamente con la biomecánica que genera esa conformidad de la prótesis. Pero finalmente, ¿qué cree que es lo que hace que eso cambie? De las presiones sobre los componentes, sobre las superficies óseas, o sobre la tensión de los ligamentos, o sobre la propiocepción de la movilidad de la rodilla.
I got a couple things, but I still need the translation one.
So he's asking about the design of the Journey 2
Yes.
prosthesis, the robotic. So he's saying that you were telling us that after a few months, your therapists and patients were saying it was different. And what were you doing different?
Right.
So he's asking, what do you think is the reason why this is different? Is it just because biomechanics, or soft tissue balance, or proprioception, or articular surface changing because of the robotic? Or?
Right, so it's very interesting because our clinic collects what we call patient-reported outcome measures. So who's forgotten joint scores, and so we assess our patients preoperatively and postoperatively. So we have a study where we have one group of patients who has a Genesis 2 knee, Smith & Nephew's original knee design dating back 20 years, a second group of patients who have the Journey 2 knee, and now a third group of patients that we're still collecting data on that have a Journey 2 knee that was put in with the Navio robotic technology. And it's still early, but at the 3-month data point collection, our satisfaction rates went from about 87% to 92%, now up to 93, almost 94%. So I cannot say specifically that it was the design of the Journey 2 knee that made our patients' scores go up, or the robotics. Maybe I just got to be a better surgeon. Maybe our pain management protocols are getting better and better. But the one thing I do know, again, is the design of the Journey 2 knee is more closely replicates the design of the native, non-diseased human knee. And if we're able to do that, and then use the technology to make sure we're putting the prosthesis in the patient with the accuracy and precision that we now can do with the Navio robotics, again, I think that matches the scores that our patients are reporting.
One question? Yeah. Doctor, how do you select the patient for a Navios surgeries? Or how does it work there in the United States? Because we have Navios here, but it's impossible to do it here.
Right. No, so access to technology is not universal, right? Even in the United States, the Navio technology is there's a significant cost to it. Okay, our patients they don't get charged more if I use Navio technology. Okay, but that is a way that some surgeons in other countries are using the technology. Hey, if you need a knee replacement, the government will pay for it, but if you want the Navio, you have to pay extra. We don't do that in the United States. It's one charge for the patient. Our hospital has a foundation, just like you guys here at Las Américas, and that foundation does fundraising, and then they help the surgeons by giving us access to this new technology through the financial support of the community, of the patients who live in the community. But it is, all new technology is expensive. Our cell phones have gotten more and more expensive, right? And so there's a price, but ultimately that price will come down as the technology becomes more universally available. It's just like anything else.
Are there some patients that pay for it by themselves?
We have some patients in the United States who live in Canada or live here in Central and South America who cannot get surgery here, and they will come to the United States for surgery. So they pay cash for that. Yes.
Thank you.
So basically, two questions. One, the role of anesthesia in the recovery of these kind of patients. Do you have any improvement?
Yeah, and that's a very good point, as I touched on a few minutes ago. Multimodality pain management protocols, meaning surgeons working with anesthesiologists, with the nursing staff, has made a significant improvement in my practice over the last 5 or 10 years. So our anesthesiologist, as we're doing here, same exact protocol that we asked the Colombian anesthesia group today, we'd like a spinal anesthetic, so the patient does not need narcotics during the surgery, and they need lower doses of anesthesia. And we do periarticular joint injections, as well as nerve blocks, adductor blocks. So those have significantly reduced the patient's initial pain. And we know from the research that if there's less pain in the first 2 to 3 days, the patients will have less pain over the next 2 to 3 months. And if they have less pain, they do more with the physiotherapist. So they can do more with their rehabilitation. So anesthesia, very important in what I do these days.
And the last question is related to, should we avoid surgery in the future? With, some kind of supplements or...
Yeah, that's good. It might put myself and some of my colleagues out of business, but we'll figure out a way to survive. That'll be okay. No, I think the future, it's almost unlimited in terms of what we can expect. At some point in time, the stem cell technology will advance where cartilage can be successfully regenerated and then injected into joints and then recover the diseased bone. Right now, it's experimental, but the research doesn't support it. But, again, who thought we'd be working with computers in the operating room theater, 20 years ago when I started in orthopedics. So. Excellent questions, by the way. Thank you. Okay, good. Everybody, like I said, ready for knee replacement, or send your mom or dad in for knee replacement if they need that. Thank you very much.
Is it possible that you do report about the first surgery?
Sure, I'd be happy to. Yeah.
This is our CEO, and it's interesting.
Absolutely.
What happened today.
All right, so today, April 11th, or 11 April, as you guys say here. So Operation Walk International, which is our charity based in the United States, we arrived here in Medellin on Tuesday, and yesterday we saw 36 or 37 patients who had been selected through the clinic for consideration of surgery. Today was our first day in the operating room. So when we came down on Tuesday, we were saying maybe we'll do 6 surgeries today. Yesterday, when we started planning the schedule, we said maybe we can do 8. And so as of 6 p.m. today, we've done 10 surgeries, which is amazing, through the support of the hospital and the clinic. So thank you very much for that. We truly appreciate that. The patients, I made rounds before I came over here. That's why I was a few minutes late. The patients are doing fabulous. They're already up walking around. I think the nursing staff is who you guys should talk to, because they're amazed at how well these patients are doing. Okay, so that's through working with the local anesthesiologist, working with the clinic who helped organize all the patients for us, and everybody in the operating room and the hospital who are making this all happen. So day one, we thought we'd do 6, we did 10, and our goal is to, before we leave, is have 30 surgeries done here for the Colombian patients. So yeah, it's a true honor and privilege to be here. It really is.
The issue is that we're going to demand more from our surgeons. So.
Well, that's why they are coming into the operating room, and we're interacting as best we can through the language barriers. But the translators have been great. But I think we're sharing knowledge, and I like to hear what they're doing here too, because I'm always looking to do things better at home, and I'm certainly I look to help others help their patients as well. Thank you all very much. See you tomorrow? Sounds good. Thanks. It's our pleasure. Thanks again for your support. Okay.